Hello and welcome to the Board of Health meeting for March 19th, 2019. I'd like to remind everyone that our meetings are web streamed and televised, and for those in attendance, I would ask that you ensure your phones are on silent mode. First, is there any disclosure of pecuniary interest? Okay, seeing none, any approval or changes, or any changes to the agenda? Okay, seeing none, I've got a motion moved by Councillor Geisen, seconded by Councillor Columbus, that the agenda be approved as presented. All in favor? That is carried. Next, in regards to the Board of Health meeting minutes, are there any errors or omissions? Okay, if not, the Board of Health minutes for February the 5th, 2019 have been circulated, and since there are no errors or omissions reported, be declared as adopted and signed by the Chair and Deputy County Clerk and affixed with the corporate seal. Moving on to our presentations. First up, we have the Medical Officer of Health update, and I will turn it over to you both. Thank you.
Thank you, Madam Board Chair. I just wanted to start this afternoon with a good news story. I'd like to take this opportunity. It is my great pleasure to advise the Board of Health of the formal appointment of Dr. Shankar Nasathuri by the Minister Elliott of the Ministry of Health and Long-Term Care. Dr. Nasathuri comes to us, as you're all well aware, highly qualified, trained, and with extensive experience, and we're very fortunate to have him as our ongoing full-time Medical Officer of Health. For those of you who were around the table over a year and a half ago to 2 years ago, this has been a long process, through a health audit recommendation. So again, I just want to say how pleased I am that we've come to this point on the journey, and I'd like to ask that we extend our congratulations to Dr. Shankar Nasathuri.
Congratulations, sir. Thank you.
So I'll take this opportunity now to ask Dr. Nasathuri, as our new full-time Medical Officer of Health, for his first update to the Board of Health. Thank you.
So, Madam Chair, members of the Board of Health, thank you for giving my team and our team here an opportunity to share our perspectives and dialogue today. When we think of public health, typically one thinks of health protection. It's the thing that perhaps lay people would be most aware of: the inspection of restaurants, the inspections of tattoo parlors, the inspections of spas, the inspection of water facilities, the management of infectious diseases and their contacts. But there are really two sides of the coin in public health. There's health protection and there's health promotion. And health promotion may not get the same level of notoriety as health protection, but health promotion is a really important thing. And today's meeting, and our team today is going to talk primarily about health promotion as it relates to preventing falls in children, and I think it'll be an excellent presentation. If I could share with you, as an academic construct, when we think of prevention, which is a key component of health promotion, there are three broad categories of prevention. First is primary prevention, which many of us might know. And academically, primary prevention is preventing a disease before it becomes clinically apparent. So that would be things such as vaccinating children or vaccinating adults to prevent them from getting sick from a particular infectious disease. It can also mean therapeutic exercise to prevent cardiovascular disease such as heart attacks and angina. Secondary prevention, on the other hand, is to try to catch illnesses or catch diseases before they become clinically significant. So a good example of that might be mammography. We try to screen women with mammography, which is basically a type of X-ray, so that we can catch cancers at its very earliest stages, and hopefully by catching those cancers early, that we can provide definitive treatment to help with survival. And tertiary prevention, which is not as well recognized, but is also important, which is the construct that once you are sick and once you've had an illness, how can we get that person back to a better functional place? So an example of that might be someone who's had a stroke, They can't walk initially, and we try to train them with physical therapy and other interventions to hopefully get them walking. Probably, and I wanted to share with you, many of you may remember this, that probably one of the best examples of health promotion relates to seatbelt laws and seatbelts. In the 50s, cars didn't have seatbelts. In the 60s, in the early 60s, they were an option in cars. In the late 60s, they became mandatory. And in 1976, when I was 10 years old, it became the statute that you had to have seatbelts. Now, what is seatbelt laws and what is seatbelt acceptance done? Well, 93% of people use seatbelts now. And seatbelts have probably saved about 1,000 lives a year in this country. So it's a big impact. But to flip it on its side, the 7% of people who don't use seatbelts are the 40% of the mortalities in the country. So in my mind, seatbelts is just one example of how health promotion can make a difference. Briefly, I wanted to share one very positive thing that the health unit has really achieved in this past month, and you'll hear more about it later on this year. So the Baby Friendly Initiative is a worldwide initiative to advance the health of babies, and a key component of that is breastfeeding. It's an initiative that was sponsored by UNICEF and the World Health Organization, and it's worth knowing that the Public Health Service achieved conditional accreditation or conditional approval for this initiative. To me, that's a really important accomplishment. I wanted to share with you what the surveyor said, and then, even more importantly, what a constituent said. So the surveyor said, as an achievement, the Norfolk County Community Breastfeeding Policy reinforces that mothers are welcome to breastfeed in public premises in Norfolk County buildings, and if the mother wishes, she will be provided a private space for breastfeeding or expressing breast milk. And that was an achievement highlighted by the external reviewer. But even more importantly, this is what some of the constituents said. This is a mother who said, quote, "The prenatal teacher was great. The classes are informative and I learned a lot," unquote. And another mother said, quote, "The public health nurses are doing a great job. They're encouraging and kind, and they've always been able to answer my questions," unquote. So from my vantage point, and I think from the Public Health Service's vantage point, it's an immense achievement to have one conditional accreditation, and the Public Health Unit is one of the 114 centers in Canada who's achieved this designation. We're happy to answer any questions or respond to any inquiries. Thank you.
Thank you, sir. Any questions from any of the board members? Okay. I have two motions. We'll just come back to the first that's been moved by Councillor Van Passen and seconded by Board Member Michelli, that the update by Marlene Miranda, General Manager, Health and Social Services, respecting the appointment of, sir, you have to help me pronounce, Doctor, how do you pronounce your last name?
Yeah, because it's a public meeting, I guess I have to give you the phonetic. It's Nasathare, but Shanker is actually quite good. So.
Okay, well, it's always been Shanker for me until I saw the last, and then I was like, well, I don't know if I can handle that one. Could we just say Dr. Shanker then?
You could say, that
As
would be
Haldeman Norfolk's Health Unit Medical Officer of Health be received as information. All those in favor? And that's carried. And next is a motion moved by Board Member Columbus, seconded by Board Member Geisens, that the update by the Medical Officer of Health be received as information. All those in favor? That's carried unanimously. Okay, next we're moving on to the staff report, which is the child falls prevention, and I believe staff is here to present the report and respond to questions.
Thank you, Board Chair Chop. I'm going to ask staff to present. Today with us, I'd like to introduce Kathy Heffer, who's the Program Manager of Maternal and Child Health Team, and she has been at the board orientation in the past. Karen Marks, who is one of our health promoters, and Sarah Barua, who's our new epidemiologist. So please welcome them, and they will be presenting the one report for this afternoon.
And this runs that?
Yeah.
Where's the machine? Okay. Oh, there we go. It worked. See, I told you. Okay,
Yeah,
Does
that
it work?
works. Yeah.
I told you I was challenged. Okay, push to talk.
Do you want to hit the next one?
Okay, so for children ages 0 to 6, falls represent a significant public health issue. Fall-related injury is especially concerning as the rate of ER visits is significantly higher for us than the rest of Ontario. Falls are associated with negative outcomes, not only for the child, but it also affects family, friends, and the community as a whole, healthcare providers, and of course the cost to the healthcare system. The rural context of Halton, Norfolk poses unique challenges in implementing interventions due to different social, economic, and built environments, conditions compared to urban settings. So, what is child injury prevention? Child injury prevention includes development and implementation of strategies and policies focused on program, increasing the protective factors, or reducing the risk of hazards for injury. The focus is reducing the chance of an injury happening, reducing the injury severity when it does happen, and of course reducing the long-term effect of an injury after it happens. So why is injury prevention important? It's important because the majority of injuries are both predictable and preventable. To be effective at injury prevention, we need to recognize that injuries are avoidable and that we can take action to keep children safe. Children 0 to 6 are our most vulnerable members of our community, specifically with regards to falls. That means broken bones, concussions, both which can affect growth and development and additional challenges both in the home and at school.
Okay, so in order to determine which type of child injury was most prominent in Haldeman Norfolk Health Unit, conducted a situational assessment, which included reviewing and analyzing local data through comprehensive literature review, which comprised of academic and gray literature, as well as an environmental scan of other like-minded health units and those within close proximity within our health unit. And once this situational assessment was complete, it was determined that programming around child falls was needed, as indicated by the data, which I will go further now. So as you can see in this slide here, this represents the frequency of ED visits that are attributed to falls amongst those who are 0 to 6 years old, so children from 2007 to 2016. And as you can see by the crude number here, in 2007, there was a total of 441 falls, which jumped to in 2016, which jumped to 594. That represents an increase of 35% from 2007. And then the following slide here, we have two graphs depicting the rate of ED visits attributed to falls and on-road injuries in Haldeman and Norfolk. As you can see in this graph, the orange represents Ontario and Haldeman Norfolk is represented by blue. Again, as you can see on the left-hand side, the falls have has increased over the years from 2007 to 2016. And this increase in rate is statistically significant. And when we compare the on-road injuries graph, which is on the right-hand side, it had steadily declined, and there was no significant difference between the rates in Haldimand, Norfolk, and Ontario when compared between specifically 2013 to 2016. And additionally, as you can see on the left-hand side, the ED rates are much higher at approximately 8,000 per 100,000 in comparison to 200 per 100,000 for on-road injuries.
So in addition to that, once we looked and we analyzed all of the data, all of our environmental scans, we looked at a comparison of local programs. So if you look on the right, the child car seat safety, those are all of the collaborative agencies that we work with on child car seat safety. And when we looked at who was doing anything with child falls prevention, there was no one. We put our name in there because that's what we hope to do, is focus on child falls prevention. So you can see that the child car seat safety is left in good hands. So our recommendation. With the significant number of children affected by falls in Haldimand and Norfolk counties, the lack of community programs, staff recommends that child falls prevention become an area of focus. A strategy which would include educational initiatives that prevent child injury. It would mean collaboration with agencies, parent workshops, and to implement or integrate into existing programs, for example, the Healthy Babies, Healthy Children program. Looking at home interventions such as safety gates. The lower rates of on-road injuries for children under the age of 6 have lowered significantly and are not of significant increase to the rest of the province. The available community resources, staff also recommend that the Haldimand Norfolk Health Unit not continue with their involvement in the car seat initiatives. Thank you.
Thank you. Any questions from the board members? Board Member Columbus.
Thank you, Madam Chair. A couple questions here. The falls that are reported here, say a child falls skateboarding, playing hockey, that's not included here, I take it, right? Okay. And I would think that there's probably a lot of falls that have occurred that haven't been reported. Do you have any indication of what percentage that would be?
Through the mayor to the board, I will have to get back to you specifically what you're looking for. But there are other falls that are attributed to other cause. Yeah, that is not reported here.
Okay, thank you.
Any further questions? Are there any programs like this in other, like this is a program I'm assuming that you're modeling on another municipality? Is that?
Through you, Madam Chair. Yes, when we did the environmental scan of like health units, we asked them what their or any initiatives or programs that they were implementing in their communities, and we had received 11 responses, and there were 4 that are implementing the same one that we're researching, the www.preventchildinjury, which is a strategy which works at parent workshops, working with community members, implementing it as part of their programs, et cetera, like the early on centers, and they all do that in existing centers, yeah.
Okay. Any further questions? Board Member Micheli.
Thank you, Madam Mayor. I'm just wondering if when falls occur and they're reported, is there ever a specific protocol for investigating whether or not the fall should have been prevented in the first place, and does that ever go further?
Through you, Madam Chair, to, how do you say your last name with apologies?
Micheli.
Michelle.
Michelle, okay. They are, like we look at falls in children 0 to 6. When we look at the data from the hospital, as Sarav had mentioned, it looks at where the injury occurred. So then we're taking it a step back and saying it occurred in the home. So how then can we support and empower parents to create a safe home environment so that these falls don't happen? It's approximately 2% of injuries that are not predictable or preventable. All the rest are predictable and preventable. So we know from that particular statistic that we can empower parents and support them to create those safe environments so falls don't continue to happen. You know, putting in a safety gate, the pressure ones at the bottom of stairs, the actual ones that have to be screwed onto the walls at the top so children don't fall downstairs. Removing any slip mats, for example. As children grow in development, so teaching them about healthy growth and development so that they know what's going to happen at different stages of development, to watch for things like walking. When they're learning to walk, children are top heavy, for example, so they'll fall over. So, you know, being a little more like within arm's reach, so they can prevent those injuries from happening. Yeah. Does that
Thank
answer
you.
your question?
Well, I guess I have one more thing that you mentioned. I'm just curious that, so these are determined to be preventable, and we try to educate parents on how to do that. But are there occasions when sometimes the investigation has to go a bit further to determine if maybe, you know, they should have been more preventable, and it's through some measure of neglect on the part of the parents? Do we go further with those?
Yeah, that would be out of my realm. I'm looking at promoting safe, healthy environments for children. That would be more of, you know, families with risk or families who need additional education as to how to keep their children safe. When they go to the hospital, I'm not familiar with that except personal experiences where they ask you a series of questions. How did it happen? Who was there? What happened? What did you do? Et cetera, et cetera. So I think they would at that point make a decision, but I honestly don't know what their process is or what steps they would take to alert other agencies. Yeah.
Thank you.
You're welcome.
Board Member Martin.
Thank you. Does this program include any synergies with the hospital or potentially Children's Aid, or to investigate that and then determine if there's a spike related to a potential neglect, or does it just stop at the education prevention aspect?
Through you, Madam Chair, to Councillor Martin. We're actually going to have the Children's Aid Society as one of our community collaborative partners because they do offer parenting programs. So we would hope that a piece of this Prevent Child Injury program would be implemented as part of their already existing parenting program so that they would be getting that additional information from their parenting staff that provide that information for their families. You're welcome.
Thank you. Just one little question about the financial component of this. I see that the number on the operating budget is $3,400. How is that number calculated, out of curiosity? It seems quite low for a program that's being...
Madam Chair, could I, Kathy Heffer is the program manager, and she would be able to respond to that question.
Thank you. So, to the Mayor, the $3,400 doesn't include the cost of staff time or mileage, so that $3,400 is really only designated to program supplies, and that amount was for the purchase of car seats that we would give to parents that we felt were unable to purchase car seat themselves.
Okay, so where will that $3,400 be allocated now then if we're not buying car seats?
So that, in the process for the child falls prevention, we hope to, we would look at potentially purchasing safety gates. We will explore that further once we get the approval from this group, but it could be for safety gates. It may be to purchase the education module for community partners.
Okay, is there any idea of the total cost with staff time and so on, specifically on this program, of the entire financial component?
For the new falls prevention piece?
Yeah.
So we do look at FTE, and predominantly this would fall to Karen Mark's responsibility, and she does have components of the Baby Friendly initiative that you heard about as well as our a parenting component, positive parenting component, and drawing a blank to the last one. So we anticipate that about 30% of her time would be spent on this.
30% of a FTE on child fall prevention.
Potentially.
Okay, thank you. Anything further from anyone? Okay. I have a motion somewhere that has been moved by Board Member Michelli and seconded by Board Member Van Passen, that staff report HSS 19-11, Child Falls Prevention, be received as information, and that the Board of Health support the Haldeman Norfolk Health Unit's decision to focus on child falls prevention. Any discussion? All those in favor? And that's carried. Thank you very much. Moving on, there are no consent items for today's meeting. Under our communications, we have 2 items under communication. One is from the Deputy Premier and Minister of Health and Long-Term Care, and one from the Regional Municipality of Durham. If I could just ask a question, these were just sent to us, there's no further advocacy on the part of Durham?
That is correct, yes.
Okay. I'm not sure I'm in agreement with some of the material in there. So, I have a motion that's been moved by Board Member Columbus and seconded by Board Member Geisens that the communication items A and B be received as information. All those in favor? And that's carried. Anything in other business for anyone?
So I know one of the questions asked earlier was what happens when children fall, and to make a determination of. I think the question was when the child falls, is there a determination to made if the fall was preventable? So as a general construct, we only can survey the children who actually presented to the emergency department. For every child that presents to the emergency department, there are many children who probably have fallen, or a number of children who have fallen whose parents do not take them to the emergency department. And that's only human, that when you have your 3rd child, you're less likely to bring them to the emergency department than your 1st child, and I have 3. So, and I think I was at the ED more with child number 1 than in totality with child number 3. And I bet you if I had 4, it'd be less. So that's one of the that's just one of those statistical challenges. But we have to work with the data that we have, and 550 falls a year that brings someone to the ED means 550 families were in some way worried enough to bring their child to the hospital. The second issue is that a fall that's significant to a parent and a child is not necessarily, quote, significant to a doctor. So a lot of children who fall do not have life-threatening injuries. They have injuries which are obviously difficult for the child and difficult for the parents, but it doesn't require investigations like x-rays or treatments like suturing or a broken bone like a fractured leg or a broken arm. But a small percentage of children who do present to the ED end up having very significant injuries, including spinal cord injuries and head injuries. So in that context, every time a child goes to the emergency department or is seen by a doctor after a fall, it's incumbent on the doctor to make some inquiry about is this preventable or not. And sometimes that goes into an error in judgment, or things might have just, child plays soccer, he hits another child. Well, those are, I don't know what, I think that's okay. But every so often that shifts into items of abuse and neglect. And if there are issues of abuse and neglect, then there's a whole statutory regime to deal with that. So I just wanted to clarify, that's sort of where, I hope that answers the question about trying to make a determination if a child has fallen, and there's an antecedent reason for it.
I have nothing, thank you.
Okay. Deputy Mayor Martin, or Board Member Martin, I should say.
Thank you, Board Member Chop. I don't know if this is appropriate right now, but there were 2 comments made in that presentation that just kind of sparked a few questions for me outside of that program, and I wondered if now would be an appropriate time to ask. There was a mention made about 30% of an FTE to be spent on that program, and then I had myself wondering, if there was a statistic to FTE staff members in the health department that are spending a certain percentage, if so, what percentage of their time dealing with opioids and our opioid crisis here in Norfolk County. I certainly know that every program is important, but that was something I wondered about.
So through the chair to board member Martin, we don't have specific percent, oh, sorry. I'll try again. So through the chair to board member Martin, we don't have specific division of FTEs for that, but as we're reporting to the ministry, and you'll soon see our annual service report come forward for your review and endorsement, but in that it does break it down to some programs associated. Our opioid strategy, Mr. Syed is actually working very actively on pulling all of those resources together to create a very strategic and coordinated effort to continue to work towards reducing the crisis that we're currently facing.
Thank you. That was going to be my next question. I know over the weekend we had a local Norfolk County OPP officer save someone's life twice in 24 hours due to an opioid-related issue. So I wondered if there's a date on a report or something that would come to council. I would be very keen to hear about programs on opioid use in Norfolk.
We do have a report coming. I believe it's coming for the May Board of Health.
Thank you very much.
Shankar, are there some statistics from other municipalities of what having 30% kind of an FTE focused on child falls? I mean, I know kids do fall a lot anyway on their own, regardless of whether or not you have a program, of what that kind of looks like, what the improvement rate is, what the savings are then to, the medical system. And is there any data on that?
So I'm not aware of any comparative statistics. Part of what we do is regulated by rule and statute and regulation. And the time spent is just not on interventions, but also to understand the scope of the problem in the community. When I think of the impact to health, one child with a spinal cord injury or one child with a head injury is such a substantive loss to that child or family. I think it's still a good use of resources. I think it's a perfectly reasonable thing perhaps for us to provide individual members of the Board of Health with what our progress is and how those resources are used. So, in relationship to resource allocation, we'd be happy to provide more information either individually or collectively on our progress related to that and how that money is allocated.
I think that'd be great. And as well, maybe if, when we get that list of all the services that Health and Social Services provides, I would be particularly interested in seeing the breakdown, now that I understand how it looks, of, within this FTE, 30% of the time is dedicated to this program, so we can see where that balance is, particularly as we see some larger needs in the community with the, with opioid abuse and so on, with maybe we need to look at kind of reallocating some of those resources to more critical areas.
Sure, and I think our team, we're delighted to share how we make those allocation recommendations. One thing I would also share is that falls prevention is both architectural items, such as making sure that children don't fall downstairs, and it's also advice that we can give individuals who are at high risk for having preventable falls. So we're happy to share that on a continuing basis.
Okay, perfect. Thank you, sir. Anything? Board Member Columbus.
Thank you, Madam Chair. To whoever can answer this, there's hardly a month goes by where I don't hear of an acquaintance or someone that I'm familiar with has been afflicted with cancer. And I think I've talked to you about this before, Marlene, as to if we can get a report. Seems to be a high incidence of that disease in our area. People keep bringing it up and they wonder what kind of statistics we have on hand as to whether we have more incidence of that deadly disease than other municipalities or other areas.
Through the chair to Councillor Columbus, Mr. Syed and I were just having a side conversation here. Were there specific types of cancers that you were looking for, Councillor Columbus or Board Chair Columbus, or just in generality for those rates that are higher in our particular region, you were looking for a report specific to that?
Right.
Okay,
Just
fair enough, noted. Thank you.
all kinds, yeah. Okay,
Yeah.
thanks.
Thank you.
That we get a report on that. Are those numbers readily available?
Through the board chair, we'll have to go back and just look at, like, some of those numbers would be readily available. We'll have to allocate some of those resources, and we can bring something likely in a few months. Please recognize that for us to bring a report to council or to the board, it takes about 2 months, so hence our delay sometimes. So for a simple example, the May reports are just being they're already completed and being circulated right now. So there is about, even before we write the report, after we write the report, there's a 2-month circulation period. So probably I would suggest summer, and we'll put that on our action list.
Okay, I appreciate that. I don't know how the rest of council feels with the direction she's taking, but I think it's important so we can answer some questions.
Board Member Hoffman.
Thank you, through you, Madam Chair, to Marlene. Just wanted to clarify in regards to the questions that were asked earlier about funding allotments for increasing support services, et cetera, to the opioid crisis. Would it be correct to say that the dollars that would be available for the child prevention injury component would be different? Are those different silos of funding?
Yeah, so through the board chair, yes, they are, and it's quite prescriptive of where we can spend some of those funds. So like as Ms. Heffer said earlier, even the 34, it's really just for what we would call things like materials and supplies, and the FTEs then we allocate from that same, like what we call buckets of funding. So it is prescriptive, unfortunately, and we can't just transfer multiple funding buckets to the opioid crisis. However, we are working towards putting as many resources as we can, because it's definitely a priority, not just for us in Haldeman, Norfolk, but across the nation.
Great, thank you very much for the clarification.
That is true, and I just might counter that in a sense of the FTEs, even those that are, as we've discussed during budget deliberations, even those that are fully funded by the government, of course, we know that they also come with a cost, and that cost could then potentially be allocated to other programs.
You are correct, yes.
Thanks. Okay, so is there anything further? I have a motion before me, or rather that a bylaw 2019-04 BH being a bylaw to confirm the proceedings of the Haldeman Norfolk Board of Health at this meeting held on the 19th day of March 2019 be passed, signed by the Mayor and Deputy County Clerk and affixed with the corporate seal. That has been moved by Board Member Geisens and seconded by Board Member Columbus. All those in favor? That's carried. And next I have a motion moved by Councillor Geisens, seconded by Councillor Columbus, that this Board of Health meeting be adjourned at 1:40 p.m. All those in favor? That's carried. Oh, well, go ahead. What time did I say? Oh, sorry, my clock hasn't been changed here. Oh, sorry. 1:40. 2:40 p.m. My apologies. No, it's all good. I looked at it earlier and I noticed that it was off and I forgot all about it. Go ahead.
Now, I had said this earlier, Madam Chair, that since it's municipal responsibility to set daylight savings time, and we have not yet passed that motion, your time is actually correct.
Oh. Thanks. Okay, meeting's adjourned.